Hello, and welcome to the Metabolic Classroom. I'm Professor Ben Bikman, a biomedical scientist and professor of cell biology. I am so glad you're joining me today for the lecture. To those who are joining me live through your membership at benbikman.com, thank you for being an insider. I look forward to getting to your questions at the end of the lecture today. As a reminder, you can become an insider at benbikman.com to gain access to all kinds of great content and metabolic goodies. Now, in today's lecture, we're diving deep into GLP-1 receptor agonists. Even if you haven't heard that term, you have certainly heard of the medications that take advantage of this. These medications have gained a lot of attention for their role in weight loss, and before that, it was gaining attention in the realm of type 2 diabetes management. And you've likely heard the name, at least the drug names, Semaglutide or Liraglutide, and if not those drug names, you've heard the brand names, like, for example, Ozempic or Wegovy. These have been hailed as, of course, breakthrough drugs for weight loss. But as is the case with so many powerful interventions that are drug-based, there's more to the story than you often hear. So in the lecture today, we're going to begin with an overview of what GLP-1 is, what it does in the body, and why it's so important. From there, as a starting point, we will look at the drugs, the GLP-1 receptor agonists, including their mechanisms of action, some of the, of course, most common brand names that you may be familiar with and may even be taking. Then we'll address some of the major benefits with these drugs. Why is it that people are on them at all? But also, what I feel is very important is for you to be aware of the other side. What else are you getting? When you pick up the end of the stick that are the so-called benefits and you're getting the other end of the stick with you, the consequences that you don't want. What are they? Why do they matter? And that's what we'll cover in the second part. But by the end of the lecture, certainly my hope is that you're going to have a more complete picture of the promises and limitations of these drugs. All right, let's get started. Firstly, as I like to frame these lectures, let's just kind of go through a series of questions, with the first question being, what is GLP-1? GLP-1 stands for the words glucagon-like peptide 1. This is a hormone that is made in the intestines, and it's generally just simply produced in response to food coming down the intestines, or in other words, eating. This is, GLP-1 falls within the family of hormones called the incretin hormones. Now, what they all have in common, and there's a handful of them, is that these hormones generally help the body process food, giving it signals with regards to digestion and handling of the nutrients. But also beyond that, they help to regulate blood sugar levels to some degree. Now, GLP-1 is a multitasking hormone because it does have many effects, and we're going to highlight some of the most relevant in the context of metabolism. And indeed, perhaps the most famous effect is that it slows gastric emptying. This means that the food leaves your stomach more slowly. So after you've eaten a meal, you're going to feel fuller for longer. And naturally, this slower digestion will result in a lower blood sugar spike, or blood sugar is going to be a little more regulated because of this. But in addition to regulating the rate at which food is moving through your intestines, GLP-1 also importantly suppresses glucagon. Now, sometimes people mix up the word glucagon with either glucose or glycogen. Glucagon is a hormone that signals from the alpha cells. So it's made in the alpha cells of the pancreas, not the beta cells that make insulin, but neighboring cells, literally packed right next to the beta cells. The alpha cells produce glucagon, and glucagon sends a signal to the liver to release the stored glucose into the blood. That would be where glycogen comes in. So glycogen is the stored form of glucose in the liver, and glucagon will signal to the liver that it's time to break down that glycogen into its component parts, namely glucose, and then to release that glucose into the blood. Now, back to the drug. By keeping glucagon in check, GLP-1 can help stabilize blood sugar levels. Now, that's a very big one, and it's one that we're going to come back to when we really discuss insulin and mechanisms for weight loss here. But by inhibiting glucagon, there is a reduction in blood sugar, and as blood sugar goes down, blood insulin is going to go down. That's a good thing. That is part of what helps the body become so much more insulin sensitive. Now, third, there's one more mechanism worth mentioning in the metabolic context, and that is the central effect on appetite regulation. GLP-1 is a hormone that normally will communicate directly with the brain, telling it to reduce hunger and increase feelings of fullness after eating. Now, it is important to note that this is separate than the effect at slowing down the intestines. So we have this additive effect where the intestines are moving more slowly, moving the food more slowly, which gives a sense of fullness in the abdominal, in the stomach. And then second, it's also telling the brain, you don't want to eat. Now, this begs another question that you might be wondering about based on what you've heard. And that is the effect of GLP-1 on insulin secretion. Many believe that GLP-1 also increases insulin secretion, which would help explain why GLP-1 is so good at lowering blood sugar. Now, I've already mentioned the main mechanism, in fact, which is that it inhibits glucagon. But because of that reduction in blood sugar, and the fact that other incretins do stimulate insulin, there's been a general thought that GLP-1 does the same. However, research challenges this assumption. And a really great study that you can find for insiders in the notes here, a study by Flint and colleagues from the Ostrup lab. That's a very good lab when you want to look up any GLP-1 work, one of the pioneering labs in Denmark. They found that various doses, including very high doses of GLP-1 in humans, actually reduce insulin levels rather than increasing them. I'm going to say that again. They found that GLP-1, when infused into humans, actually reduced insulin after the people ate a carbohydrate-rich meal. In particular, the study measured insulin and glucose levels in obese individuals during GLP-1 infusion and found that both were reduced. Now, of course, this is likely due to both GLP-1's ability to slow gastric emptying, which reduces the amount of glucose entering the bloodstream at any moment, but also the inhibition of glucagon, which of course in turn helps glucose stay in check. So this finding and other work from the Ostrup lab in particular does suggest that GLP-1's role in blood sugar management may not be directly tied to insulin like many people have thought. So that is something you can join me. That sentiment is something you can join me in rejecting with enthusiasm. Now, let's move into the drugs. So everything up until this point within the main part of the lecture has just been a review of the physiology of GLP-1 as a hormone in the body. But it's no surprise, a hormone with so many benefits has been taken advantage of. I don't mean that in a negative way, but in this case, it has given birth to the GLP-1 receptor agonists. So these are drugs that mimic the effects of GLP-1 in the body. Where it's an agonist, it means it's acting like GLP-1 at its own receptors. These medications, of course, will bind to GLP-1 everywhere in the body, including the alpha cells in the pancreas, within the brain, and within the GI tract. Now, I mentioned those specifically, but at each of these instances, it's going to amplify the natural actions of GLP-1. And with those tissues in mind, it's no surprise then that these drugs have been shown to reduce glucagon, and thus help control glucose. That's the effect at the pancreas. It's going to suppress appetite. That's the effect at the brain. And of course, it's going to slow digestion. That is the effect at the GI tract. Now, there are several GLP-1 receptor agonists available in drugs. Now, each of these will have varying doses. In fact, some of the drug names that are different are actually the same drug, just used at different doses. Now, just for the sake of being thorough, I wanted to give a brief survey of the most well-known options that you might have heard of or that many people are using. And this is kind of in no real order, although in this case it kind of starts with the oldest of them, exenatide. Exenatide is the drug name with coming in brand names Byetta and Bydureon. Byetta, in particular, is a twice-daily injection, while Bydureon is a once-weekly version of the same drug. So they have different half-lives and thus kind of different effects as well. Another version of a GLP-1 receptor agonist is liraglutide. Liraglutide comes in the brand names Victoza and Saxenda. Now, Victoza is used to manage type 2 diabetes, while Saxenda, a different dose of liraglutide, is marketed for weight loss, and both of them are daily injections. Another one is dulaglutide, which has the brand name Trulicity. This is a once-weekly injection, and it's generally just a diabetes therapy. And then the last one is arguably the most famous now, and that is semaglutide. It comes in the forms of Ozempic and Wegovy. Ozempic is used for type 2 diabetes, while Wegovy is used for weight management or weight loss. Both of them are once-weekly injections, but also now, and probably increasingly common, you can also get an oral version, so a pill form, albeit with less effect, called Rybelsus. Now, just as a fun little point of physiology, GLP-1 and these drugs are peptides. Peptides can't be orally consumed because they will get broken down by digestive enzymes into their component amino acids. That's why all of these are injectables, and why the Rybelsus, which is kind of more coated and designed to try to get through the acidic environment of the stomach, it can work, you can do it, but it has a much lower effect. It's just harder to get that peptide absorbed from the GI tract. It's just easier or more effective to do a straight injection. Now, among all of these, semaglutide is probably the most famous now, in part because of just how effective it is. Clinical trials have shown that semaglutide readily results in at least 15+% of body weight reduction, which naturally fosters some enthusiasm. But the weight loss isn't surprising, right? With the controlled glucose, by inhibiting glucagon, insulin levels come down very, very well. At the same time, the person has such a better sense of satiety that they're just eating less. And that addresses the two parts that I've talked about in previous metabolic classrooms when it comes to body fat and fat cell regulation, that you need both of these variables to be down. You need insulin to come down, and you need energy. Now, you have instances, and I won't get into this, even as I'm getting on the tangent, I'm trying to pull myself back because I've talked about it abundantly in the past, just maybe to elicit some enthusiasm for you to go back and watch that. As much as you have in mind the idea that it's just calories maybe matter more, that is not true. If you lower insulin, the body starts wasting energy so readily that you have a lot more energy you can be eating and even be losing weight. So insulin matters enormously when it comes to weight loss. Now, these drugs address both, like I said, reducing insulin and reducing calories because of increased satiety. So naturally, that's going to make someone quite excited about it. However, there is a counter to this enthusiasm in the form of the side effects that I just believe not enough people highlight. And remember, I'm just your friendly neighborhood scientist. I'm not your clinician, and I'm certainly not giving any kind of clinical advice with these drugs. But I simply, as a biomedical scientist, can't help but wince a little bit when I see the enthusiasm and almost the blind affection people have for these drugs. Like every drug, there are consequences. And indeed, every drug is a matter of balancing the consequences you want, like weight loss, for example, in this case, versus the consequences you don't want, like we'll get into now. I'm kind of starting with what I consider to be the most dramatic and serious of all of the consequences, which is mental health risks. One of the growing concerns with these drugs is the impact on mental health. For example, a large cohort study found that patients taking these medications experienced significantly higher rates of depression, anxiety, and even suicidal behavior. What they found in particular was that those, when compared with the people not taking the drugs, those on the GLP-1 receptor agonists had an increased risk of major depression by 195%, an increased risk of anxiety by 108%, and an increase in suicidal behavior by 106%. Those are pretty significant numbers. In fact, meaningful numbers. They were statistically significant, but even beyond that, that is such an increase that I'm going to use the other word, meaningful. There's something real happening here. So while these drugs may suppress food cravings, they might also dampen the brain's overall reward system. This is something that is called anhedonia, a reduced ability to experience pleasure. So it could be that they are, yes, finding reduced pleasure from eating, and so they're eating less, but it may also be reducing pleasure for other parts of life, like various other interests are no longer interesting to the person anymore. Okay, another one that I consider to be very significant, but also not a lot known, is muscle loss. That is another significant concern based on some pretty robust evidence. So while the GLP-1 receptor agonists, of course, are highly effective at promoting weight loss, but remember, what we are made of isn't purely fat, and the weight lost isn't purely fat. Studies have shown that up to 39%, so about 40% of the weight lost with semaglutide comes from lean mass or fat-free mass. And that includes muscle. Now, it includes all kinds of things, including some water, but it also includes muscle and bone and other tissue. This is, of course, particularly concerning because muscle is essential for just overall health, metabolic health, longevity. Muscle mass and strength is one of the greatest predictors of longevity. Muscle beyond this plays a very important role in regulating blood sugar. It helps you, it's necessary for mobility and overall just maintaining healthy metabolic profile. Not losing muscle, given its metabolic rate, also can compromise resting energy expenditure. So your fasting or resting metabolic rate will go down. Your ability to control glucose is going to go down because muscle is the main consumer of glucose. Now, that leads me to just state now a very immediate thing that anyone should be doing on these drugs is just doing anything you can to keep muscle mass. In fact, this is further evidenced in the pursuit of these drug companies to try to combine the GLP-1 receptor agonists with other drugs or molecules that will help maintain muscle mass. That, of course, is not easy to do. It is very difficult to stimulate muscle growth if there's no stimulus for it. In other words, resistance training. That's something very important. Okay, one other effect that at first glance seems paradoxical is the effect on fat tissue. This is a process known as adipocyte. Adipocyte is the name of the fat cell. Adipocyte differentiation. And this is involving a protein within the fat cells called PPAR gamma. Now, GLP-1 receptor agonists, particularly liraglutide, others, to my knowledge, like semaglutide, this phenomenon has not been confirmed yet. But liraglutide has been shown to activate a receptor called PPAR gamma, which plays a key role in adipocyte differentiation, or the formation of new fat cells. Yes, you heard that right. So this drug is stimulating fat cells to multiply. While this may improve the body's ability to safely store fat while the person's on the drug, it creates a challenge, of course, for when the medication is discontinued. If the patient stops taking the drug, and they do often, like I'll get to in a moment, and starts to regain the weight, these newly formed fat cells can fill up, of course, potentially leading to a higher body fat than before they ever started the drug, or at least a higher body fat percentage. This is especially concerning, of course, because the loss of muscle mass during treatment can further skew the body composition towards fat. So the findings generally, these two collectively present a pretty troubling effect. As I'll get to in a moment, people get off the drug or the drug begins working less well. Now, over the person's weight loss period, let's say 2 years, they've been losing fat. Studies suggest that for every 10 pounds of fat or 10 pounds of weight they're losing, 6 pounds is fat, 4 pounds is not fat, including lean mass like muscle and bone. So they're getting leaner, and smaller overall. They're just losing weight. But they get off the drug. One of those compositions of body comes back very quickly, which is the fat. And in this instance, where there's evidence to show that there is the production of new fat cells, their ability to store fat has gone even higher than it was before. At the same time they were making fat cells, although all the fat cells were small, that's why they were losing weight. But as they gain weight back, The lean mass is very stubborn. It does not come back very quickly. So even 2 years, let's say they're on the drug for 2 years and they lose 50 pounds. They get off the drug and they gain 40 back. They may say, well, at least I'm still 10 pounds lighter. Yeah, but you still may be fatter than you were before, given how much muscle and bone you lost. I know that's a pretty sobering perspective, but these data do in fact suggest that that is not an unlikely outcome. Okay, now a moment ago I mentioned the diminishing effects here, or to invoke a term of economics, diminishing returns. So let's look at sweet cravings and the long-term effects. One of the initial benefits of GLP-1 receptor agonists, like semaglutide, is their ability to reduce cravings for sweet food. This effect is particularly appealing for those who struggle with sugar cravings, as it can lead to just better choices and then support weight loss. But this is something that I feel very strongly about. I believe one of the best uses of these drugs is actually to help people who have food addictions, who with the best of knowledge and with the best of support continue to really struggle to reduce their sugar. I think there's an opportunity to use those drugs in that context. People aren't really describing it as such or using it as such, though. But nevertheless, the long-term effects aren't quite clear. A 2-year clinical trial known as STEP 5 investigated the impact of semaglutide at 2.4 milligrams, which is a pretty common dose, and looking at the control of eating. In particular, the study measured participants' cravings using the control of eating questionnaire. And with that questionnaire, they found that while there was a significant reduction in cravings, sweet cravings at 20 weeks and 52 weeks, so kind of a half a year and 1 year, this effect diminished by the 104-week mark, so 2-year. The pattern of waning efficacy raises some pretty important questions about how sustainable these changes are. As the sweet cravings return to baseline, it's very likely that patients are going to find it more challenging to maintain dietary changes. Of course, additionally, the study highlighted that semaglutide significantly improved overall eating control during the early phase of treatment, such as reducing hunger and improving a sense of fullness, but these improvements diminished over time as well. Collectively, these results do suggest that the patient needs to be reinforcing and getting some education on how to eat well rather than just relying on the drug. In a way, this self-discipline in a syringe only works as long as the drug is effective. So there needs to be a coupling of the use of the drug with some serious education to try to get them to start learning how to eat better, because even those who stay on the drug find it increasingly hard to control their cravings. Now, compounding this concern is the fact that within the United States, up to 70% of patients on these drugs get off the drugs at 2 years. I'm going to say that again. So even people who have not been told to get off the drug, at 2 years on the drug, 70% of people have gotten off the drug. In fact, at 1 year, it's 50%. So that's a pretty sobering statistic. So even people who are trying or maybe still actively losing weight, which they are at 1 year, 50% of people on the drugs get off the drugs. And then at 2 years, the number has continued to climb up to 70%. So these are people who, for reasons we may not know, have gotten off the drug, maybe because their weight loss has plateaued, or maybe because they're tired of feeling nauseous. They're sick of feeling sick, which is really what is happening when they say that I don't really have cravings. Part of it is because their stomach just is a little bit upset all the time. But whatever the reasons, or they're tired of feeling depressed and suicidal, because that's an increased risk. These up to 70% of people are getting off the drug. And this is not just a unique thing in the United States. A totally separate group in the UK found that their numbers at 2 years were about 67%. So a shockingly close statistic to what was shown in the US. So I'm pretty comfortable stating, well over half of patients who go on these drugs are interested in, and indeed they do get off them at 2 years. And that all really just brings these ideas into focus, namely the concern with the composition of the body. that if you have been stimulating the production of new fat cells, even though they've been shrinking because insulin is down and you're eating less, but at the same time you've been losing fat or shrinking your fat cells, if you've been losing lean mass, when either the drug it stops working as well, or you decide to get off the drug entirely, you're going to gain that fat back quite quickly. Again, one of those weights returns very rapidly, much to our collective dismay. Now, one more consideration to keep in mind, which further plays into perhaps people's interest in getting off the drug when they can, or as soon as they can, and that is pancreatitis. And nearby the pancreas, it's also gallstones. So I'm kind of wrapping these into one kind of quick idea at the end, because there's a little less evidence on these than the others. So firstly, GLP-1 receptor agonists have been also associated with pancreatitis, and then the gallstones. Pancreatitis, or an inflammation of the pancreas, it's still kind of rare, but it is serious. And there have been documented cases of acute pancreatitis linked to the use of these drugs. And in this case, the person will typically suspect there's a problem because they will have severe abdominal pain. Now, that has to be you have to see through the normal nausea and discomfort in order to sense that pain, because the person's generally not going to be feeling very well in their stomach. Also, the other one I mentioned here, of course, is gallstones, and that is much more common, especially during the active weight loss phase. The general effect here is, in fact, a feature of physiology. We have long known that the best way to reduce gallstone formation is to eat fat. Now, why might that be? The gallbladder is a little kind of organ tucked beneath the liver, and it is concentrating the bile made of bile salts and cholesterol esters and things. It's concentrating the bile that the liver's making. And it's this little sac filled with bile. And what bile does, of course, is emulsify fat. So when you have a blob of fat, fat wants to clump together. And if it clumps together in a big blob as it's coming down out of the stomach and into the small intestine, we can't digest it very well. Our digestive enzymes, which target fat digestion, can't get into, they can only work on the outside of the blob. And so it's a really slow process, and you would digest very little of that fat and absorb very little, of course. And so the blob of fat generally just moves through the intestines, and you're only able to have digested very little of it. Bile salts, or bile in general, help come in and start breaking that up into small little blobs of fat. That's the emulsification. Now, for the gallbladder to empty, you need to eat fat. That is the stimulus that empties the gallbladder. And so, in fact, it's very common for people who go on low-fat diets or who are losing weight through restriction of fat and low calorie, which is what's happening with GLP-1 receptor agonists. It's not a surprise that the gallbladder just sits there, filled with the bile, rather, wondering, when can I empty myself and squeeze to eject all this bile? It can't, because the person's eating so little fat. So that bile just sits in the gallbladder and sits in the gallbladder. And the longer this mix of bile sits, the more the molecules start coming together. And then as it starts coming together, what was once a kind of highly viscous liquid then starts turning into a sludge. And what was once a sludge starts turning into actual masses, or a little stone, the gallstone. And thus we now have a gallstone formed. And any time the person is eating fat in the future, or when the gallbladder is trying to empty, it's squeezing, but it has all these stones in it. And so the person's going to feel a significant pain. Again, this is not uncommon. Anyone who's losing a lot of weight through restricting a lot of fat because they are following what I would consider to be the bad advice of going on a very low-fat, low-calorie diet, which is just ultimately going to make them very hungry, even still they run a significant risk of developing gallstones and then having their gallbladder taken out. Again, the key here then, this has been admitted in the NIH documents for decades now, the solution to preventing this is, of course, just eating fat. All right, let's wrap it up. No one can argue that GLP-1 receptor agonists are powerful tools for weight loss and blood sugar control, but they are not without trade-offs. From mental health risks and muscle loss to fat cell development and the diminishing returns over time of the drugs, the medications do come with complexities that demand some careful consideration. So if you are considering these drugs, remember my advice as your friendly neighborhood scientist, they must be paired with some ongoing changes to lifestyle. My suggestion as your friendly neighborhood scientist is to use the lowest effective dose, combine it with a low-carb diet, and significant attention on resistance training to do everything you can to make sure you're not losing a speck of lean mass. All right. Thanks for joining me in today's lecture. Thank you for letting me be your guest professor in the metabolic classroom. Until next time, more knowledge, better health.